Good morning, everyone. Today is my great pleasure to present our three speakers, all of them very, very outstanding. And I would like to start with Joan Henriksen, a PhD. Joan began her career nearly 30 years ago as a registered nurse, and she worked in cardiology and pulmonary units. Then she went to earn her PhD in religious studies at the University of Iowa, and she did research that was focused on topics like moral distress, conflicts of conscience, and preventing ethical conflict. Then she completed her postdoctoral fellowship at the Mayo Clinic in the bioethics research, and started at ELINA in April of 2020, and currently serves as the only professional ethicist here. Joan provides ethics consultation, proactive rounding, ethics education, and support of scholarship. Joan chairs the System ELINA Ethics Council and participates in organizational ethics processes as well as policy review. Joan also is an active part of our heart transplant team and often participates in our heart transplant meetings, which is extremely beneficial to our patients and our team. Next speaker is Kristin Hjartardottir. I'm very proud I can pronounce that name. She's a RN and DNP in psychiatric and mental health department. She graduated as an RN from the University of Iceland in 2007 and then worked at the National University Hospital of Iceland on an inpatient psychiatric unit. She then attended the University of Minnesota School of Nursing, where she got her DNP. And in 2015, she came to Abbott Northwestern Hospital to work on the psychiatric consult liaison service. And she mainly works in the cardiac units and also is really an integral part of our advanced heart failure team, helping our patients resolving different conflicts and issues. And also doing a lot of consultations on the floor, collaborating with families and also physicians and providers. And then our last speaker, Katherine Katzung. Dr. Katzung is an attending physician in our emergency department, and she serves as the chair of the department as well as a consultant for the Minnesota Poison Control System. And is an assistant medical director of Mission Detox Center in Plymouth, Minnesota. Dr. Katzung graduated from University of Minnesota, then completed her residency in emergency medicine, followed by additional fellowship training in medical toxicology. So today, they will be speaking on what does it mean to help, ethics, mental health, and addiction in cardiology patients. Thank you very much for being here. I'm looking forward to it.
I'm just going to run the screen here for Joan.
Yeah. Thank you. Thanks for the introduction and thanks for inviting us. I apologize up front for my voice. I am not in person because I'm recovering from COVID and I can't be with you, and apologize that I don't speak very well right now either. We don't have any conflicts to disclose, and our objectives were on the CME materials. So, yeah, thank you. Let's get to the topic. So healthcare at its core is an altruistic endeavor. The entire point is to help people. And the ethics word for that is beneficence. It's the positive side of the coin with non-maleficence, or do no harm. Folks in medicine will often say, first, do no harm. But that's not quite right? First, no one went into medicine or healthcare in order to not hurt somebody. You can avoid harming people in all sorts of jobs. You went to help people. Second, in healthcare, we often harm people on the way of helping them. There's hardly anything we do that doesn't have some sort of downside or risk or burden. So figuring out what's the right thing to do is all about balancing whether the good parts outweigh the bad. It's not okay to say, well, just do good. And if that balancing isn't hard enough, the calculating, the weighing, the risks and benefits, all of that is done within this complex question of who gets to decide which good thing is worth pursuing. So even if you think you know how to help a patient, whether what you're doing is helping, actually depends on how that person constructs what's good and what is worth taking risks for. So then that means that we have to find out what the person considers good and worth taking risks for. And that is the realm of values. So helping people requires that we understand their values. You do this work all the time. You just might not think of it this way. So our talk today is meant to provide some observations and perspectives from outside your regular field of practice to maybe prompt you to think slightly differently next time you encounter one of these cases where it can seem really hard to help the patient. Next slide, please. So Dr. Katzung, Kate and I, or Kristin and I, we're going to give a high-level overview of our fields, our separate fields. Then we're going to try and take the approach that we'll take at the same common case, a scenario, and talk through some questions we might ask. We're going to propose some traps that could be avoided and offer a suggestion or two from our own disciplinary perspectives. All three of us are in fields where people wish there were clear, straightforward fixes or big, obvious right and wrong answers, but sadly, we're not able to deliver those to you. We only have a modest aim, really. We're going to show you how we begin to think through some of what seem to be most challenging cases. Next slide, please. So our anchoring case, this is a compilation. It's from published cases and then also from some patients we've seen here. So our patient is 44 years old, has had an LVAD for a couple of years, has chronic driveline infections, even with surgical debridements and antibiotics. He's hospitalized now, and the team is considering device exchange as a medical option. But they worry that his mental health, his past, and possibly current substance use, plus poor adherence, make it a really bad idea to offer him the procedure. His family help, his support structure aren't strong. He says he's not drinking or using drugs, but there's some reasons to think that's not so. Our VAD coordinators find him hard to reach. They worry that he doesn't manage his pump or his dressings very safely at home. He doesn't get himself to the infusion center as scheduled, so it's getting harder and harder to ensure he's actually getting his antibiotics. Now, if he would say, this is too hard and just too much, or he would say, I don't want to do this anymore, this team would probably find it reasonable and respect his choice to limit treatments. But our patient instead says, I want to live. And anytime someone lays out this option of maybe de-escalating interventions, not starting antibiotics again, he says something like, well, why would I do that? You people just want me to die. This is the kind of patient that's hard to care for. He's non-adherent, maybe he's addicted, he's depressed, he's anxious. And what does it mean to help this patient? And how might the three of us help you think it through? So we'll start with clinical ethics. Next slide, please. Clinical ethics is a discipline, and we reflect on the intersection of values in healthcare. It's that simple, though really complicated. The content of ethics is values. Values, what we hold as important and central, how we make meaning, how values motivate our behavior. Values frame everything we do. They color how we see things, how we respond to other people. Now, each person comes with their own constellation of values, constructed over time by unique stories, experiences, influences. Now, if everybody just kept their own bubbles of values to themselves, maybe it'd go fine. But people and values interact. That's when there can be friction, there can be tension, conflict. Of course, that's when it becomes really interesting, and that's where ethics does its work. It's the reflection. We live our lives, bumping into others and their values all the time. And ethics is really looking at that spot, that intersection. Next slide, please. So what does ethics do? Well, we identify the values at stake in the tensions. We consider different ways that the values could be prioritized, and then we analyze the reasons for prioritizing them the various ways and try to argue for the better and worst ways. So there's not really a right or wrong, but there are better and worse, defensible and undefensible choices. It depends, really. It depends on the reasons that we're making the choices. Oh, next slide, please. So in this case, what sorts of questions would ethics ask? Well, for sure, we would want to know the values behind the tension. And that starts with the patient. So what does the patient value most? How does he think through what he's experiencing? What does his response to what the team offer say about his values? You know, does he maybe value independence and driving his own life story over values like harmony or getting along with other people or following group norms or even being healthy? It can be hard for us to understand people who don't have health near the top of their list of values. Most clinicians I know hold that one really tightly. Excuse me. To figure out the tension, ethics also has to hear from other people. What's at stake for them? What are they valuing in this situation? So in considering withholding a device exchange, the team might be prioritizing stewardship of resources, loyalty to colleagues, respectful behavior towards other people. Excuse me. Ethics would want to highlight why we would not offer the treatment the patient says he wants. Sometimes these sorts of cases hinge on tension around which goals are worth pursuing. It turns out that subconsciously humans make judgments about the quality of life of others. We do it all the time. It's natural. It's very human to do so. The key is that when there is values tension, like in this case, we need to separate out different dimensions of quality of life and make our judgments conscious so we can actually deliberate about them. Now, there are pieces of quality of life that clinicians should be talking about. What's the most likely functional status the person will achieve given the medical scenario? Now, that is quality of life, the quality of life expression. And we're going to be able to tell them what's the quality of life that they can expect. That's a piece of expertise that you as a clinician should provide. But whether the quality of life is acceptable or not, now that's up to the person who's living the life. That part's not ours to decide. So ethics would ask a question about quality of life and acceptability of the likely options to the patient. And then ethics would also ask of this decision-making process as a whole, are we being consistent rather than arbitrary? The more arbitrary a decision, the more likely it is based on hidden values, things we haven't really explored, or it could be based on unconscious bias. So if this patient were more likable, would we be more willing to proceed? And then I'd ask, is likability a morally relevant factor in prioritizing? Well, maybe it is, but let's at least be honest about it and add it to the deliberation. This is what we value, and this is what we're saying here. If this patient didn't have a history of substance use, would we be more willing to proceed? Now, maybe this is both clinically and morally relevant, but we can't weigh it in the balancing, and we can't weigh it honestly unless we talk about how we're viewing it and how we're valuing it. Next slide. That leads to the tempting traps I want to mention. So ethics keeps it top of mind that what we value influences everything. We might like to think that science is totally objective and value-free, but that's just not true. You maybe remember from your early science classes, even how the most basic studies are designed depends on what the investigator sees as important, right? What gets funded certainly depends on what the grantors think is important. We interpret papers we read, we interpret data through our lens of what has meaning for us. And then over time, values get baked into practices, and that makes them just harder and harder to tease apart. Just think about the reckoning that's happening right now around glomerular filtration rates and race, if you know that story. Talk about embedded values and affecting clinical practice. I'm just saying that it can help to stay humble and accept that even our understanding and our logic is conditioned by our values. The second trap might be the thorniest one. And most of us believe that capable adults have free will. That's where the whole autonomy and respect for patient autonomy ethics thing comes from, right? It's natural for us to assign moral responsibility for people's choices and behaviors. We're taught that from an early age. That's how the world works. So what is tough in science and clinical training, we're also taught that pathophysiology is not blameworthy. It took a long time for healthcare to help society believe that cancer was not a moral failing. A lot of people still believe addiction is a moral failing. Yet we know it's not all that straightforward. So all choices have consequences. We understand that. Like if I never check my blood sugar, I don't give myself insulin, you can predict that I'll end up with problems. Is that my fault? Well, yeah, okay. Do I deserve to suffer the consequences for my choices? Yeah, maybe. Does that release clinicians from the need to provide or prescribe my insulin? Yeah, harder. It's a hard balance. What we want to be alert for is when we notice ourselves or our teams headed down certain decision pathways and then justifying it based on this personal responsibility issue. Again, the key is to have the courage to stop, notice, dig in, question ourselves, be honest, and really wrestle with the values that are in tension. So next slide, please. So that leads me to the thing to try, the observation or the suggestion. I'm trying to argue here that all clinical decisions are a combination of both data and values. Every choice is based on interpretations of what is more important and what is important. I propose that some decisions don't have clear direction from best practice guidelines or random control trials, or there are those decisions that bring up tension and disagreement about the right thing to do within the team or between the team and the patient. Now, just consider that these might be more values-weighted decisions to start with. When those arise, allow yourself and the team to talk about that part. Let it become part of the discussion. Then the next courageous step I propose is that you keep track of the values-based reasons and the process of reasoning. Doing so allows us to come back around and do a few things. So we could see if we're making similar decisions among similar cases. We can go back, we can watch for patterns of groupthink. We can watch for patterns of bias over time. We can check our reasoning. We can check our decisions against what we claim we value, what we say we value as a program or as an organization. The advanced heart failure team at Allina does this great thing in having these regular, consistent conversations of the whole team. Each week at rounds to bring everybody together. I see it as an amazing opportunity so that the open deliberation that I'm proposing around values-heavy decisions can even possibly happen. So a philosopher of ethics, Margaret Urban Walker, she says, the role of clinical ethics is to encourage clinicians to think of moral questions about the therapeutic decisions as a matter of public analysis rather than a matter of intuition or private conscience protected by professional authority. This is a shift in thinking for a lot of people, but it's basically saying you should be able to justify your moral decisions on the public square. The idea is to build a structure where there can be this visible process of moral negotiation. Of course, for it to work, the structure space has to be safe. People have to be able to trust they will not be at risk in speaking up, especially when it's about stuff they value. But it's possible. And the advanced heart failure team is on its way to building this moral space where the reflection can happen. And I think that leads to sound values-based decision-making. So I appreciate the chance to be with you. I know I didn't solve the case or anything. I just wanted to share some of the thoughts and approaches from my discipline of ethics. So now I'll hand over to Kristin. Thanks so much. I look forward to more conversation.
Hey, good morning. I'm Kristin. I'm the nurse practitioner on the consult liaison psychiatry service here at Abbott. I thank you for having me. So the reason why we're three here is because, like, Joan called us and said, hey, can you come and do this with us? Is because, like, these discussions, like, never happened in a vacuum. Like, we're never just, like, I'm never, like, in my office with a closed door trying to solve this problem of my patients, right? So it's always, like, in this discussion atmosphere. So I'm just going to talk a little bit, and then Kate's going to talk a little bit, and then we really want to have a discussion because, like Joan said, we're not going to solve any of this. But it is no coincidence that for the most complicated cases, it's the three of us on that discussion. So that's when they call me or someone on my team and Kate's team and Joan to come talk about patient, I want to just say it, patient problems, like decision making. What are we doing here? So my kind of maybe just maybe the hill I stand on, right? People with mental illnesses get less quality care in the medical system, like the global one, right? So often I'm advocating hard that people with mental illnesses are accepted into treatment programs, that they're giving the opportunity to get medical treatment for their illnesses wherever, whenever, wherever I show up. But I also know that sometimes the symptoms of a mental illness and the problems that come with a mental illness can cause difficulties with medical treatment. So for instance, a patient with schizophrenia might not believe he was sick, or might not believe I'm a practitioner, or might not believe I'm giving him the right medication. So these are like interrupting. It's hard to treat people with severe mental health symptoms. The depression, we've talked about it in this group with cardiology, the high correlation between cardiovascular diseases and depression. And depression, for instance, reduces adherence. So severe depression has been shown to reduce adherence to both medical treatment and mental health treatment. So often when I come in to these complex cases, they're not doing what we want. And right, that's kind of the crux of the problem. And often if people carry a mental health diagnosis, the question is sometimes, is it because they are depressed, anxious, have a personality disorder, X, Y, and Z? And sometimes, yes, sometimes that is the answer. Sometimes their symptoms are interfering, but sometimes it's a lot of other things. And I think that our job in kind of sorting that out is to figure out what's the primary factor, maybe be underlying why people are not doing what could help them, right? I try to avoid not doing what we tell them to do because as an oppositional child of the 90s, I won't do anything what anyone tells me to do. Because other factors absolutely, according to research, play a part. Education level, substance use, that's why we have Kate here, higher risk of psychosocial issues, financial issues, housing issues, transportation issues. There are all these other things that could be standing in the way of people doing what they need to do to help themselves. So if I try to answer the three questions, what do I want to know? What should I ask? One, I would always start with, what are my preconceived ideas of mental illnesses? What are my thoughts and what are my experiences? Who do I know with a mental illness? How do I see that impacting lives? How do I possibly have biases based on experience of persons that could be impacting how I think about people with mental illnesses? So that's probably the first question. I what's my preconceived ideas? Then I would ask, what are their understanding and insights? Because people with mental illnesses, PTSD, depression, anxiety, they have a lot of strengths, a lot of survival skills, they've built up a resilience that is quite magnificent if you look for it. But sometimes it's hard to get at what do they understand about their illness? What do they understand about the illness that we are diagnosing them with, like heart failure? what are their insights into like, how does this illness connect with my behavior? Like, how can I impact my illness, et cetera? And then don't, and this is like a, maybe it's a more of a avoid. So not assume that a certain behavior is directly related to a diagnosis of a mental illness. So for instance, someone missing appointment, don't assume it's because they're depressed. Someone forgetting to take their medications, don't assume it's just anxiety. Ask, be curious, like what is standing in the way? Like we would do with anyone who doesn't have a mental illness. The other things I would try to avoid is, and it kind of ties into this, like, because mental illnesses impact how we think, how we learn, how we feel, how we behave. Like there are multiple layers of where the symptoms come out. So when we are teaching people about complicated illnesses like heart failure, cardiovascular diseases, don't assume they're getting it all. So one, like, and I always point to this one, that treatment can cause anxiety, depression, and psychosocial issues. I mean, we know that people who have VADs placed are at higher risk of developing severe anxiety and depression afterwards. It takes them a while to adjust to a very big change in their bodies and in their lives. So sometimes when I say, don't understand, depression has, for instance, and heart failure has, of course, impact on how we perceive things and remember things and our cognitive abilities. So we have to kind of I've sat in on consults where I've had a patient fully alert, fully with you guys, nodding their head, even asking appropriate questions. And then when checked in later, does not have a recollection of what we just told them. And there's so many things that can cause this: anxiety, denial, and depression, and cognitive impairment, right? So we have to kind of if I were to avoid one kind of is leaving the room, would say often to him, being like, well, that went well. So come back at it, right? The other thing I would, related to my first question of what's my preconceived ideas, is trying not to assign our experience with a previous case diagnosed with a similar condition to a new one. We all do it, right? So there's a trend in psychiatry. I give a delirious patient Haldol, and now I'm like, yeah, that went really well, and now everyone gets Haldol until they have a bad result, right? So we all have that. It's a cognitive bias in our head, right? So often we do that is okay, I have this patient who has all these things. Last time I had a patient who had all these things, it went really badly. So I'm going to be more conservative here. I'm going to hold back. So we trying to steer away from that and see each person as a person with their own unique challenges and own unique strengths and resiliency too. And then, what would I like you all to do? Just call me. No, I'm kidding. So I would love it if we were better at, and this is where we work at, everywhere in the healthcare system. I know there are little signs to this, and we're trying really hard to work on this, is to integrate mental health into our care, into our primary care, into our clinic care, community care, and hospital care. Because there is no health without mental health. And we have to start seeing this as a very, very fixed together issue. We can't just silo anymore. So I think that's still what my passion is everywhere I go. So if we can do that more, that would be great. So I'll leave it to Kate, and then hopefully we can have some questions.
Perfect. I think this is a good take home too that Kristin wrote. Many of these patients that we are seeing are being seen by someone like myself or Kristin for the first time when they are critically ill and decisions are needing to be made like on the fly. It's not necessarily the patients that have been involved with addiction or mental health for a prolonged period of time and on a slow trickle downward, kind of that spiral. They're coming in crisis through the ED and the advanced heart failure team, the cardiothoracic surgeons. Everyone needs to make split-second decisions, which can be very distressing morally, and I can kind of bring in here more, but that is a very important point, especially what I've noticed from my perspective on doing addiction medicine consults or seeing as an ER physician, seeing these patients come in through the ED. So I'm an addiction medicine physician. Many of us have other specialties, so I also work in the emergency department and through poison control for toxicology. A lot of people don't know what an addiction physician does, especially in the hospital setting, because we're pretty rare. Addiction medicine consult service, I would say, is a newer trend, probably over the last 15 to 20 years. Previously, speaking to silos, addiction medicine has been siloed in this outpatient realm where your primary care provider notes that you may have some issues with substance use disorder, and then they refer you to someone like me, or you get referred to treatment. There has been this void, and I noticed that coming on out of training with being able to do addiction medicine assessments in the hospital, and hence that's why I've this big push for an addiction medicine consult service, which is now coming to fruition and very supported by Alina, especially at Abbott Northwestern. But what do we do, and how does that differ from what Kristin does, what the social workers or care coordinators do? So our specialty training is in assessing patients for a substance use disorder, all comers, all kinds. Kristin's background can also assess and diagnose substance use disorder, so we do overlap. Where we come in is consideration for medication management for those patients. Again, there's a limited number of medications that are approved for various substance use disorders, so things like buprenorphine, methadone, naltrexone, acamprosate for alcohol use disorders. The primary ones that you're going to see us seeing are opioid use disorder, which in the fentanyl era and the whole opioid epidemic is just blowing up, and what we're seeing primarily in the hospital. And then I think more in the VAD patients, probably alcohol use disorder leading to their dilated cardiomyopathies. And then the one that I find the most unfortunate, also probably VAD patients, would be methamphetamine or stimulant use disorders. And from my perspective, there's just not good studies and good medications I can use to help these patients. There's some Hail Mary stuff I could consider, but it's not going to be the be-all, end-all. They are going to need to be integrated into a more of a complex program for treatment, mental health care, peer recovery services. It's not like I could just throw Suboxone at them and they're going to maintain and be able to be more compliant with everything. And then I think the biggest perspective of what I've done, especially in a newer site that's bringing this on, is education. There is a lot of perceived biases about patients with substance use disorder, and I think I do spend a decent amount of my time working, just educating people. And these are more just even curbside consultations, talking with people, not necessarily formal presentations, but being that we're here and this is what we do. And so the one thing I need to take home is that addiction is not a moral failing. I feel that this is the big take home in the past 10 years. It is a chronic relapsing remitting disorder. It has brain disease. There is changes in your brain structure and function and neurotransmitter production over time. So yes, you may go out and start using, heroin with friends and it becomes a social thing, but then you slowly get involved in this kind of binge, intoxication, withdrawal, and then you get this preoccupation with it. And eventually it comes to the point where I feel that most of our very severely ill patients that we're seeing are at this like withdrawal negative affect point where they are using just to maintain their new normalcy. They're not using to get high. It's to stave off their withdrawal symptoms and feeling horrible about themselves. And if you talk to the patients, like withdrawal is one of the worst feelings in the world for them. And so they're just looking for that new high. I mean, I think that's part of why we see patients that are using in the hospital. We're not adequately treating their withdrawal. Things along those lines. So who else do I need to help? I cannot do this in a vacuum. That's the important thing. And I think speaking to the silos of medicine, no one can do this in a vacuum. So social work is integral to what I do, working with care coordinators, social work for a lot of the medical parts of things, the licensed alcohol and drug counselors. So when you consult addiction medicine, you get me. There's different consult orders, but then you also would put in a consult to a substance abuse counselor. Those are our licensed alcohol drug counselors. They have specialized training in doing kind of the formal assessments for treatment programming. I can help with the medication aspect, going through an assessment, seeing what's motivating my patients. They're the ones saying, are they appropriate for an outpatient program? Do we need an inpatient program? Do we have to get a Rule 25? So our team works very closely with our LADCs. And then of course, dual diagnosis is very common with substance use disorders. So working with Kristin's team, for example, mental health, or say a patient comes in through the ER, acutely depressed, suicidal, and then are cleared, going through opioid withdrawal, then I'm working with the inpatient mental health providers to help stabilize them while they get to their next level of care. And then I think an often ignored part of what we do is harm reduction. Not all of our patients are ready to do exactly what we say, like here, get on Suboxone, go complete your Rule 25, go to treatment. So sometimes you have to just meet them where they are. And this is a discussion where, okay, well, you're not ready. I had one in the ER this weekend I was on for the holiday, not ready to stop using. So we talked about clean needle exchange programs. Here's your naloxone. Please use this. You could save someone else's life. He had just been saved by somebody else giving him naloxone. And kind of putting it in that perspective. And if and when you're ready, we're here and can give you more resources. So when I go to see, I frame this more as like when I see a patient, like the 3 questions I ask. So the first I ask is to tell me your story. These patients come from varied backgrounds. It's not all the same. A lot of them have come from lower socioeconomic status. I have patients that don't have a phone. So this whole concept of telehealth being amazing for everybody, some of my patients doesn't work. Why do we have a bridge clinic? So that I have a bridge clinic so patients can walk in and see me because they don't have phones or they have unstable housing. They're living out of a car. And this is where working with the social work and case management helps because they can refer and do those sorts of kind of components of it while I'm seeing them for the medication aspect. And maybe, just maybe, me putting them on Suboxone is the first step to start them to take the next step. And we can work for it from there once they've kind of stabilized some of their brain chemistry over time. And then obviously a big thing is, are you ready for change? Like I said, not all patients are ready to stop using. And it's not I should not put my judgment on them to say, well, they know it's bad. They know that it's harming their mental health, it's worsening their lives. Me acting like a mom, like shaking my finger at them, isn't gonna change them. In fact, if anything, it's gonna make them more heels dug in and like oppositional defiance. I'm not gonna do that. And then the other thing I like to ask is, what is tried for you and worked? A lot of people have had adverse experiences with Suboxone, maybe because they're getting it in an ED, getting it too soon, precipitated withdrawal. I can tell you if a patient has gone through it is kind of their own personal hell, and it takes a lot to get them convinced that we can do this right without them feeling horrible, and to not give it up as a something to consider to help stabilize them. And a lot of it is just discussion and even education with these patients. A lot of them didn't even know some of this stuff is available to them. Just basic studies, so outcomes. A lot of the research I've had is based more on IV drug users and infective endocarditis. There's just not as much literature out there on substance use disorder and LVAD patients. But treatment retention rates have found that 6 to 12 months is what they're looking at. If we start a patient on opioid agonist treatment, so if I'm meeting them where they are in the hospital and we're starting Suboxone or even methadone with referral to a methadone program, they can have retention at 6 to 12 months of 40 to 75%. Yes, it's not 100%, but nothing is going to be 100%. But if you have a patient you're seeing that's got advanced heart failure or infective endocarditis, and we can at least start them on something, you're getting some sort of percentage of them being hopefully retained in care and going on. Methadone maintenance, this other study was superior to drug detoxification. It's the Suboxone era now more so, although we will have patients on methadone and are able to do that. So 71% versus 20% just to drug detoxification. Studies have clearly found that detoxification protocols just don't work and that they're not the most ideal for patients. And then a cohort study of IV drug users, this was one that I found with native infective endocarditis. So 91% had survival at 4 years, But this cohort was a pretty less severe cohort because 82% did not require surgery. And I feel that that's not necessarily the case of what we're seeing, at least at Abbott, because I feel as a quaternary facility, the reputation of our cardiology service, which I think is amazing, is that you will give a second chance or at least consider a second chance. I know places like the university or Mayo that gets one and done where they will at least consider it here. I'm not saying that, they do it, but at least the patients have a second chance to be seen and considered. So I think we have a different, more probably severe cohort than other hospital systems. And then much older studies showed a 60% mortality at 30 months and a 45% mortality at 22 months. So traps that I try to avoid and would love people to try to avoid is not treating their withdrawal. We've all seen these patients in withdrawal. They can be mean. They can say horrible things. I've been called every name in the book, and it just doesn't faze me now. But then if you see them once their withdrawal is treated, they're honestly a different person. They're much more human and able to engage and kind of talk with you and go through your story. And then the other trap is writing a patient off because they just don't want to go along with the plan that you want. You need to meet them where they are now. We all have an idea of what would be the perfect plan for our patients. For mine, it would be we get you started on Suboxone, you're engaged with your mental health provider, you go to treatment, and you're working with your cardiologist. It just doesn't work for all people. And then the big one that I've found, especially in the population that I see coming through the ER and in my bridge clinic, you don't minimize the importance of social determinants of health and the ACEs score, so adverse childhood experiences, on their current situation. A lot of it, they've gone through horrible things in your lives. If you like when you have them tell your story, that affects where they are today, how they're able to cope. They do have resilience. I mean, I'm amazed at the resilience that my patients have. They know to come to an ER when they're sick. They may not stay because they go through withdrawal and they may leave AMA, so, but they do know to come back to us. And then just also not recognizing your own biases and how they contribute to your perceived experience. And I think we've all kind of touched on that here. And then this was an article that Joan sent out. So Gail D'Onofrio is an emergency medicine provider that is an addiction med researcher. These are all providers out of Yale. And I thought this article was very interesting in that it gave kind of an example similar to how we did with the patient. It was infective endocarditis, and it has an internist on it, a lawyer, and then a ethicist. And they talk about medical utility, not futility, and just viewing that these patients are not futile. It's not futile care. And Joan may want to weigh in here, but these are all kind of arguments that people have made to say that the care is futile. And this is just saying, we can't withhold care because we don't like their lifestyle. I mean, I don't like my patients that are untreated diabetics that come in every week in HHS or have every complication known to man from their diabetes, but it doesn't mean I'm going to withhold getting dialysis or withhold their insulin. Treatment non-adherence, again, we've kind of all talked about this, going into those factors that lead to non-adherence. For me, sometimes it's my patient doesn't have a phone. They can't get to an appointment. They don't have transport. And then the low cost effectiveness. So societal costs, as the individual provider looking at an individual patient, saying that you're withholding care because of the societal cost, this article is saying is not necessarily the most valid argument at that time. And then using the poor allocation of scarce resources. Yes, an LVAD, for example, is a scarce resource. That is a more in-depth situation, like a heart transplant, organ transplant. But they're talking about like valve replacement in this setting. It should only be considered if there's a critical scarcity of resources. So is there somebody else that needs this VAD? Or for an example of like an endocarditis patient, is the OR, one OR, we've got 2 critically ill patients, we have 1 cardiothoracic surgeon, which one should they go to? Or having been involved, and Joan was on these discussions too, in the COVID area, who gets a ventilator? That's what they're talking about with kind of the critical scarcity of resources. And I think those are all I have. I think we wanted to open this up to questions from the group.
Did Joan leave?
Joan, did you want to add anything? Yeah, I think she is.
No. Thank you. I appreciate that we all kind of wrap together to provide a similar message. And we endorse a paper that's offered there. If you would like to see more robust arguments, it's nicely laid out in that paper. I hope that even if there aren't a lot of questions, I'd love to hear Kate and Kristin kind of talk back and forth. So that'd be fun too.
We can talk back and forth. Does anybody have questions or cases, concerns? Yeah.
I have two questions. One, I was on service a week and a half ago, and I can think of two cases where I think addiction medicine may have been useful, and I just wasn't even aware that that was a resource available to us. So first is,
Please consult us.
yeah, help me understand, how do we do that?
So the consult orders are confusing. I am the first to say I've been trying to change them for 2 years. It is IP consult to addiction medicine. That gets the physicians. The IP consult to comprehensive assessment, addiction medicine, gets the LADCs to do like a Rule 25 assessment. We're trying to change that to make it easier, more intuitive. But for example, I know advanced heart failure consulted, my colleague did a consult. It was a patient being considered for transplant, I think recently this week, with marijuana use disorder. And it was more of an assessment kind of consult regarding, I didn't do it, so I don't know the details, but just like, can we facilitate, they were smoking still, I think vaping marijuana, and is there a way to go to edibles or other, it was medical marijuana, so it gets into this whole scenario of marijuana and transplant coordination. But even if it's not like a medication per se, we still can do the assessment and say, you know, this is a methamphetamine use disorder, they're meeting criteria.
And then the second question is not about addiction medicine, but more about kind of ethics questions. So it's in helping our quality assessment for our surgical teams, we often look at our 30-day mortality and we'll review cases. And it's not uncommon that we'll find patients who went through an operation in discussion with the surgeon, and then post-operatively they have complication within the bounds of expected complications that they may or may not recover from in the coming weeks. And family comes in and says, whoa, 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 this isn't what they would have wanted. I'm now their decision maker. This isn't consistent with their goals of care. We're done. And it leaves the surgeons frustrated because they feel if they're given the opportunity that they have the conversation with the person who was advocating for themselves prior to the surgery, that they may have gone further and kind of recovered from the situation. And so it creates this tension for the teams. I'm curious kind of what the thoughts are about how to best approach that.
Joan, did you hear that one? I love that question.
Yeah, I heard. Would you guys like to talk about it first? Then I'll have.
I can have a stab first and then Joan. So one of my, because informed consent, right? It's like so I, as a mental health practitioner, am like a massive advocate for including the family at all stages. And I have seen, we often have those very difficult conversations about, do you want surgery? Here are the risks and benefits, with no one else in the room. So there's no one there. So when that happens, right, there all of a sudden there was a conversation between, and it's how we do medicine. It's based on our medical model of I'm a physician, you're an individual, we have a relationship. But the relationship really often extends when you're in those. So I would say, if we can change that practice, that would be a huge difference for a lot of my patients, for instance. I had a conversation with a husband. They were proposing a very serious surgery. She had said yes. She was noted to be very depressed and very withdrawn, a little bit with a regressed childlike affect. And I had a conversation with the husband afterwards because I couldn't get any contact with her. She wouldn't talk to me. And I'm explaining to him in my very lay language, because I'm psych and not medical, what this surgery will entail, including being intubated and waking up intubated. Just to find out this woman has a massive, horrible trauma history, horrible. And that is impacting her ability to participate in any of her care. And I think my opinion was impacting her ability to give informed consent. So I asked him to have that conversation with her again, with the surgeon again, to make sure that she understood that piece. And then they declined. So again, I think it's very important that we are including family beforehand, before they can't tell us what they want. Does that help?
It does. The challenge the surgeons will encounter is the family that's remote.
Yeah.
And then because of a complication now flies in.
Yeah.
And you know, so, but I
Yeah.
think that's good guidance, but
Yeah,
that's.
get him on the phone.
Yeah.
Like, I'm like, okay, Joan, did I miss anything like ethics-wise there?
Well, I really appreciate you bringing up the including the family part to make sure that it's a mutual understanding of the situation. But I would, as you told the story, remind that things change, circumstances change, people's understanding changes, and their way that they're valuing the situation and the benefits changes as well. So when people have informed consent conversations, especially about, you know, intense procedures, you know, it's not that the patient is actually signing a contract. We can't hold people or compel them to finish what we started. And I understand, I think, really the pressure of the system on the surgeons and the 30-day mortality rate and the thing you were describing is really where the problem is. They don't have the flexibility to account for people's stories and what they find important, and how they are able to change their mind. We can't compel people to hold to something. We don't have people sign contracts. And so we need to remember that while it's difficult, it most often is appropriate and justifiable to allow people to change their mind.
Yeah, I think you're spot on about the tension. I think that we play this game of, I'm forgetting the economics term of essentially trying to anticipate how you rate things if you experience those things, but until you experience them, you're always going to rate them wrong relative to how you rate them in that situation. So I think that is the tension, is that the surgeons are under pressure to achieve fantastic outcomes, and at times they feel their hands are tied in terms of how they could best achieve that metric. But to be consistent with goals of care, that is the tension.
I also think it's like maybe a little bit on us as providers. I think consent, when especially listening to, you know, what you guys we were talking about here, and I think we are those who do procedures. I feel we're all guilty of basically brushing it off, and you know, and I spit out, you know, like stroke, heart attack, renal failure, and death. And procedures I do, I mean, it's really nothing, you know, right heart caths, MEMS, and biopsies, although you can kill someone with a biopsy. And I think that there is a tendency, because of rush and everything, you know, PA comes in, you know, we'll sign here, and I think, you know, I think we should be more serious about those things. And I know many cases where people are like, oh, who's my surgeon, or who is my, you know, who did that? So I think it's on us too. And I think we as cardiologists, we have our hands tied too, because, you know, we don't do like cardiac surgery. And I don't think there's a big push for 30-day mortality, but there's no big push, you know, for that. And I think surgeons who do, you know, advanced therapies are extremely good at it. And I've heard all of our surgeons talking to it's like a, you know, Dr. San, or, you know, physicians who are no longer here, you know, Dr. Lodowicz, this is like a half an hour conversation. It's a half an hour conversation. It's a big deal. And in fact, sometimes like Ben would say, well, I want to talk tomorrow. I don't have time today to get that consent. And I feel that should apply. I mean, you know, CAB can be a big deal, you know, and aortic surgery is a big deal. So again, biopsy can be a big deal. So I feel.
I think you're right. There was something else that I thought about when you were talking in terms of like using the bare minimum of like, do you understand what I said? And I think that a lot of my people who have chronic mental illnesses, they have what we call a sensitive brain. So they're higher risk for post-surgical ICU complications like delirium. And it takes them longer to kind of like, so, you know, anticipate it, have that conversation. God, I lost my train of thought. There was a point there I wanted to make. It happens. So no, informed consent is not a one and done. Oh, palliative, that's what I was gonna say. So the other thing is most of our research in terms of mental health and heart failure is that we call palliative too late. Like these end of life, these like, what are you willing to do? What are you, what is quality of, it's the values that Joan was talking about. What's the quality of life that you like see and are willing to aim for? And if we can't get, what are you willing to do? Like, how are you, are you, like the family saying, he would never do that. Oh, no. He had that conversation with goals of care people who said, I'd be ready to be on a ventilator while I'm recovering. You know what I mean? So we have have those conversations of if things go badly, where do you want us to stop? So everyone, it says, like, bring palliative care earlier when you're diagnosing people with a fatal illness into the conversation.
Just to follow up on Dr. Bradley's question, is there any advice on how to set the stage for you if we order a consult?
For addiction medicine?
Yeah.
Don't let us come in blind. I usually I would frame it as we have concerns about your substance use and potential how that might be contributing to your health. I'd like you to, if you would take the opportunity to speak with one of our doctors who wants to talk to you more about that. It doesn't have to be judgmental. There have been some consults where we do not make a diagnosis of substance use disorder. They may be opioid dependent, but they're not, and this goes back to what is addiction. Addiction is aberrant behavior. So you can be dependent on opioids, but not an addict, by all means. Addiction is where you start to have aberrant behaviors such as that are affecting your daily life, like you're increasing the amounts you're using, yes, tolerance, but you're declining to go to work, or your drinking is interfering with you being able to be there for your children. You're putting yourself in risky situations. You're not taking care of your diabetes, for example, because you're intoxicated all the time. We do those assessments, so that's what we're looking for. There could be somebody with chronic back pain, and I feel they kind of get turfed to me sometimes. I know we have a chronic pain service, but I always call it the teeter-totter of there are patients who are opioid dependent that are starting to exhibit behaviors that are concerning to their teams, be it the cardiologist, the hospitalist, and we get brought in, and I have to frame it as, I'm not saying that you're an addict, but there's some concerns, and we need to talk about this. Like, why are you gone to the emergency department to get your IV Dilaudid instead of taking what the cardiology team has prescribed you? This is a specific patient that's come up. To me, that's a little bit of a concerning behavior. Tell me more about that. But it might not mean that they meet like a DSM-5 substance use disorder. So you can frame it as a discussion, I think, not a judgment.
I was just wondering, is marijuana something, and maybe you kind of answered my questions with dependence and addiction, but seeing all these people in their 20s and their 30s with the edibles and
it's going to get worse.
Yeah.
And their 40s and their 50s.
And their 40s
Yes.
and their 50s.
I've seen
60s. Yeah. I mean, to me, it's like, okay, or my kids are like, oh, that's not that bad. And do you go through treatment for marijuana, or
People do. I feel, and again, I come from the inpatient world, so I'm not consulted on marijuana use disorder. I think it is more of an issue that I've seen, at least as an ER physician, in my adolescent mental health patients that are coming in, where they'll go to Hazelden. There's Baby Hazelden, which is over in Plymouth, which is the adolescent Hazelden unit, versus Center City, which is the adults. So I think you see more of it in adolescents where they're being treated for it. But I can tell you there are plenty of people that probably meet criteria for a marijuana use disorder, but they're pretty high functioning.
We're going to see more of this.
And you will, where it's just.
I mean, my patients use marijuana as a treatment, medical marijuana for PTSD, for instance, and then the psilocybins are coming, and then everyone's microdosing mushrooms. Like, it's going to be, like, we're going to have this conversation ongoing.
We'll be giving you a lecture on microdosing psilocybin and how that's contributing to cardiovascular care.
Yes. Well, thank you. Joan, any last comments?
Thanks everyone for coming and thanks for letting us have this